All right, chapter 22, video 2. All right, so continue with my neurosurgery, my brain surgery, whatever it may be, nursing management. Again, I want to make sure that I've only got them about 20 to 30 degrees. All right, I don't want to sit them straight up, don't want to lay them flat. That's very important. Let's see here. They'll probably be on bed rest. That's another important one. We've always talked with surgeries, we typically get them up pretty fast, but not with a brain surgery. There's lots of pressure there. Remember, even with a lumbar puncture, we can lose spinal fluid and cause that huge headache. Think about when I've had an open brain injury or I've gone in to have surgery on my brain. Probably lose quite a bit. So I'm really thinking that they're probably going to have a pretty nasty headache. Cover a draining ear with a sterile gauze pad and change the pad periodically to look for drainage. Again, I'm going back to that otorrhea. I want to make sure that they don't have anything leaking out. I might see some of it post-operatively, but that's something I would definitely talk to the surgeon about. Hey, should I be seeing this drainage? Instruct the patient not to blow his or her or pick her nose, which is a big one. Big. All right, do not plug the nose or ear if there's drainage of CSF because the blockage may increase the ICP, intracranial pressure, okay? So, no, it's not a great thing if it leaks out, but that's not mean that I want to absolutely plug it up. I mean, if it's coming out my nose, it's already out of my cranial cavity anyway. All I'm doing is causing pressure, and I really have to watch that pressure, okay? If I have increased ICP, that pressure can't go somewhere. I can have bulging of the eyes. I can even have herniation in my brain down through my foramen magnum, down where my brain stem is, and have it push out. Remind the patient that he is not to change his position in any way unless he has been told it is all right. For the first little while, I'm probably going to be there to make sure that we change positions correctly, okay? So, let's see here. All right. So, on 506 is instructions for care of a patient with a head injury. Pay attention to that one. I always had this part highlighted about legal and ethical considerations. You don't see a lot of those in the book, but when you do see them, they're pretty important. So pay attention to that. ICP, or increased intracranial pressure. It says etiology and patho. Any lesion or fluid accumulation that begins to take up space within the cranial cavity causes an increase in the pressure within the cavity. Remember, my brain's inside that dura. I've got that fluid around it encased into my skull, and there's nowhere for that pressure to go. So if I have increased fluid around my brain, then all it's going to do, because my skull does not move, all it's going to do is push it on my brain, and it's going to cause a lot of pressure. So there's lots of things that can happen there. Like I've said before, is if it's bad enough, I can actually have protrusion of my brain through my foramen magnum where my brain stem is. And then, you know, obviously that's not good. So I really wanted to watch that ICP. I've even seen patients, I can remember way back in the day when I was going through clinicals, I saw a patient in neuro ICU that had a shunt coming out of the top of their head to drain cerebrospinal fluid out. They've got better ways to do things like that now, but that's been a minute ago. I don't know that you'll see a normal ICP, but it doesn't hurt to remember it, 0 to 15, so I know if it's above 15, I'm probably in trouble. Signs and symptoms, the earliest sign of ICP is lethargy. Please remember that one. That one's always big, is lethargy and decreased consciousness, accompanied by a slowing of speech and delay in response to verbal cues. I could have papilledema, which we've talked about just a few minutes ago, with swelling of the optic discs. When ICP rises, it affects the oxygenated blood perfusion of the brain, and tissue hypoxia occurs. Nerve cells are particularly sensitive to hypoxia and cannot be replaced once they have been destroyed. All right, so pay attention to that. On down below, it says that I may even see fixed pupils. Okay, so remember, neurochecks, I'm looking at that perla, checking those pupils. Clinical cues, it says abnormal pupillary responses can reverse to normal if the cause of the increased ICP can be resolved. Classic signs of increased ICP under clinical cues, hugely important. Star them, memorize them. All right, treatment. I can give osmotic diuretics, and the big one that you'll probably always see is mannitol. All right, and that's going to help pull fluid off. And it sounds silly to put a fluid in to pull fluid off, but remember, it's osmotic. And I know what about osmosis? That fluid follows, so I'll be pulling fluid. So remember mannitol, okay, because that's always a tricky one, because I'm thinking, again, why am I putting fluid on to pull fluid off? Okay, so I can use those. Let's see here. I'm going to watch if I'm using mannitol. I'm definitely going to watch that fluid and electrolyte imbalance, because I am causing a pull. It goes on to say to make sure that I keep them 20 to 30 degrees elevated for that head. I'm watching the Glasgow Coma Scale very closely. It says a score of 9 or less is an abnormal CAT scan. The surgeon may insert an intraventricular catheter into the lateral ventricle. So what we're saying is when I'm left with that patient, I'm having to make sure that I'm keeping up with that score, and I'm having to make sure I'm keeping up with those vital signs and those neuro checks. And if anything goes awry and my Glasgow Coma Scale goes below 9, you know, I need to make sure that my physician's aware every step of the way. They're going to send them for a CAT scan. Then I may have to have something like one of those shunts to pull it off. So, let's see here. On the next page, you've got some abnormal breathing patterns, and that's very important because when you have a brain injury, you'll see some of these. Usually you'll see a Kussmaul's respiration when it comes to a brain injury of some sort, but definitely you're going to see some apnea, so pay attention to those. It goes on to say stuff about barbiturates are sometimes used along with continuous brainwave monitoring when patients do not respond to more common therapies. Their purpose is to induce heavy sedation and slow metabolism, thereby decreasing the ICP. That's a big one. Temperature control is achieved by placing the patient in a hypothermic blanket for cooling. Now, that one's a hugely important one too. And that goes back even to the nursery. In the nursery, if I have a baby comes out and I think they've had some kind of brain injury, possibly from maybe even a vacuum or forceps, the first thing that I usually do is start to cool them down. And when they get them to Children's, I'll put them on a cooling cap. So I'm really looking at a hypothermic state. Diabetes insipidus is on the next page under complications. Remember, diabetes insipidus is not what we would normally think is a diabetes at all. Diabetes insipidus is I cannot stop peeing. My brain is responsible for releasing that hormone, that antidiuretic hormone that says, hey, you're peeing too much, stop, because you're losing too many electrolytes. Well, I've got a brain injury now, so my brain can't do that for me. So the result is that I've got diabetes insipidus, and I just pee and pee and pee. Well, I'm going to see urine that's very clear. It's not concentrated because I'm not really getting rid of any impurities. I'm just getting rid of water. So what I will see is probably a buildup of impurities on the inside, even though I'm losing massive amounts of fluid, because that fluid has to sit in my renal tubules long enough to pull impurities out. So remember, I don't have that time. As soon as I've got fluid going in, it's coming right back out. No time to concentrate anything, no time to pull impurities out. So I'm going to see probably a big mess up in my fluid and my electrolyte balance when it comes to diabetes insipidus. Let's see here. Injuries of the spine and spinal cord. Etiology of that, usually I've had some kind of accident when I've had a problem with that. Just remember that whenever I have got, depends on the severity of the spinal cord injury, and you've got a really awesome picture on 510. Usually if I've got some kind of severing of the spinal cord or severe spinal cord injury, I will not have feeling from there down anymore. And if you look at it, say I had an injury at T1, okay? If I had an injury at T1, look at all of my nervous system that comes off of everything from T1 down. And that's a lot, all right? That would be probably everything from my shoulders down that I would lose. Maybe even, no, probably my diaphragm down. I'd have to think about that. But wherever I have that spinal cord injury from there down, I've lost a lot.